My topic for discussion today is upper extremity arterial disease. Upper extremity arterial disease account for about less than 5% of patients with presenting with limb ischemia, with majority cause being the autoimmune and the connective. Upper extremity ischemia is less commoner than the lower extremity ischemia. Most common etiopathogenesis being upper extremity ischemia is being again classified based on the anatomic location, that is the large and the small cell arteriopaths, and also based on the vasospastic and the vaso-occlusive diseases. Usually, the vaso-occlusive diseases are associated with a worse prognosis with increased risk of tissue loss and with serious symptoms at the time of presentation. Sorry, sir, I'm just not able. Vasospastic etiologies are more responsive to, while occlusive demand surgery. Palmar and distal arterial occlusive diseases um, most are the most common upper extremity arterial occlusive, whereas the large vessel disease, including the arteries proximal to the wrist, account for about less than 10%. Account less than 10%. Large vessel disease, again, we classify them as the acute and the chronic arterial occlusive. Small vessel, chronic arterial occlusive. Acute upper extremities, where the patient usually present with symptoms extremities, patient present with symptoms and 2 weeks of the majority of them presenting with the embolic or the acute ischemias are of cardiac origin, almost nearly around 75%. The most common site for the emboli is basically a brachial artery, followed by the axillary artery, contributing 60 and 26%. Coming to the causes of the upper extremity ischemia, most cases, around 61% of the cases, are the embolic ones, mostly associated with atrial fibrillations, valvular heart, isolated ischemic heart, effective endocarditis, ventricular and it. The other ones being the atherosclerotic ones, where usually patients are having the comorbidities associated with diabetes. Ones with the renal failure involves the arteries of the hands and the digits. The subclavian artery and the brachiocephalic trunk are upper extremity locations which are associated with atherosclerotic disease, which are responsible for the upper extremity. The ones are the traumatic injury, penetrating mechanisms which can cause injury to the named vessels and also present with acute secondary to thrombosis. Vascular injuries could be both direct and direct injuries, some from penetrating direct injuries, something like a bullet or a ones which can cause projectile, uh, usually present with transections or thrombosis, and indirect injuries usually results when the trajectory of the projectile is close to the artery. That examples being the subclavian artery thrombosis due to severe traction injury on shoulders, axillary artery injury which results by humeral dislocations or humeral neck fractures, and brachial artery injury from the midshaft fracture or the supracondylar fractures. Patients again with thoracic endovascular aortic repairs usually nearly up to 40% of the cases may the upper extremities keep the stent grafting, where we may tend to cover the subclavian artery origin mostly on the left side. The other causes could be the arterial axis complication, the arterial thrombosis or the dissections, when we usually use them for the hemodynamic monitoring or for the diagnostic procedures like arteriography, may have local axis complications leading to acute hand acute arterial dissections, mostly the type A dissections, which tend to uh, extend more into the great vessels of the upper limbs, may present with acute ischemias. Usually, spontaneous subclavian or the axillary artery dissections are very rare, which are usually secondary to that of an autoimmune etiology, as a Takayasu arteritis or chain cell arteriosus, so be one of the causes. Thoracic outlet syndrome, due to the arterial compression, subclavian artery compression related to the cervical rib or the anamus first rib. Uh, this is typically due to that of the extrinsic compression and distal thromboembolism following a post-stenotic aneurysm are the most common cause for the acute upper limb ischemias in arterial TAS. The iotitis or arteritis, basically we're talking about Takayasu arteritis. This Takayasu is basically a large arterial disease, usually affecting the aorta and its branches. Young females, 40 years old, with a recognition which requires a high index of suspicion based on the clinical presentation, even in the early systemic inflammation phase, which is often non-specific. The presenting symptoms during the acute inflammatory phase or during the occlusive phase may overlap, but distinguishing is important for determining the treatment. The clinical presentation may have pulses in the blood pressures in the upper limbs, so may present of upper extremity. However, there could be advanced symptoms such as ischemic rest pain and tissue loss, which are and chain cell arteritis is also basically arteritis involving the large and the medium, so more than 50. Also, one of the rare causes of upper extremity is radiation therapy to the upper chest also result in subclavian which lead to upper. Second is the dialysis access steel syndrome, which we usually about 3% of our patients. Patients really experience symptoms of steel, that is usually having a where the brachial related to this AV axis also presents as one of the conditions called as ischemia, which has a profound. Usually, patients may have palpable pulse, but that of the distal, despite receiving immediate treatment, may have permanent deformity. Autoimmune disease, basically distal artery occlusion is causing hand and patients in this population have high prevalence. The conditions where we mostly small of pathology of the hand includes scleroderma, mixed Sjogren's rheumatoid arthritis. Scleroderma being the most common, about 80 to 90% patients of this phenomenon. The prevalence of primary renal less than 1% human population. First, understand basically interstitial ischemia in response to cold, coffee, or emotional stress due to vasospasm. So this is idiopathic Raynaud's syndrome. We call it as Raynaud's phenomenon syndrome with identifiable pathology or associated disease. Where we can see of the autoimmune disease. Etiopathogenesis, where there is epithelium of the hand. The bodies. So being the so see in arthritis, there is extra articular the GI lungs vasculitis, which involves the again immune mediation that we see. Also seen in patients with a genetic such as an infection which leads to an immune with vasculitis so as well. Sjogren syndrome, arteriopaths with phenomenon. Burgers disease, sized heart, mostly seen in the lower extremity. Associated with the diagnostic tobacco abuse, the hand. See this most replacement. The kinetic injury parted to the of certain frequent so initially present with the vas by that of a diseases where when patients present uh, the condition known the injury, the hypothenar. This is due to fibromuscular sensitivity, where we can see the demonstrable underlying where there's going to be a progressive following medical present frostbite, these injury digits with a mild is usually present features of mesos with arterial disease. A large was the causes which genital AV upper limb ischemia, basically means upper limb clot. Cause being the ischemic of the hand are responsible for subclavian steam, arm blood pressure, PP difference more than 20. Uh, Results, the likelihood of symptoms due to person by arm patients are usually during during the exertion of the arm. Brachiocephalic occlusive disease, stroke or time may include arm claudication, still ischemia with examine the pressures on and evaluate the different segments if all the listening finger to be checked for the sclerodactyl auscultation of the supraclavicular and to check for the bruit indication of subclavian stenosis due to the cervical ribs or first ribs that needs to be looked. Differentiation of the large artery that of the small diseases that is with the but with that of a immersed in a cold water temperature for around 10 degrees for a period of 5 minutes, and then following which the decrease in the diameter of the vessels are determined. If there's a more than 45% decrease in the diameter of the vessels, we consider as a positive cold challenge test. And in patients with all these tests are not significant, then hypercoagulable screening test also is being followed. And coming to the imaging studies with the most commonly is the duplex ultrasonography. Detection of eye velocity flows indicating more than 50% stenosis. Monophasic post-stenotic flow can alter flow in the ipsilateral subclavian artery stenosis. Seen more than 70% of proximal subclavian stenosis is witnessed. In cases of subclavian steel syndrome, flow reversal is being assessed in the to be assessed in the ipsilateral extracranial vertebral artery by hyperemia testing. Severe stenosis of occlusion of the right brachiosaphalic is associated with reduced force elasticities even in the ipsilateral subclavian and the common carotid arteries. In case of doubtful duplex ultrasonographies, imaging with CT angiogram and magnetic resonance angiography MRI, they provide excellent resolution and are less invasive. In case of embolic diseases, 2D cardiography to look for LV apical clots, anything is recommended. And invasive arteriography is generally reserved for patients with unexplained distal artery occlusion in an asymmetrical distribution to rule out any surgically correctable proximal lesions. Both the upper extremities needs to be imaged usually, and the presence of significant bilateral disease with unilateral symptoms are usually suggestive of a systemic disease. The medical management, usually lifestyle modifications, that is avoidance of cold, avoidance of tobacco, and with the commonly used medicines, calcium channel blockers, that is nifedipine, which is a vasodilator, complications being fatigue, ankle swelling, that we usually see in patients with nifedipine, and in patients with ARBs such as losartan, which is angiotensin 2 inhibitor, prevents vasoconstriction and uh, prevents aldosterone-induced vasoconstriction. Fluoxetine, which is a selective serotonin uptake inhibitor, prazosin, and also these act by basically as vasodilators, and sildenafil and silastazole phosphodiesterase 3 inhibitors, and also endothelin 1 receptor blocker, that is bosentan. They're the ones which can be used in the small vessel ischemic diseases, which basically help in peripheral vasodilatation and relieve the symptoms. Usually the indications for revascularization in patients with upper extremity ischemia, usually patients with severe disabling symptoms, bilateral stenosis, stenosis with ipsilateral AV fistula for dialysis, patients planned for the coronary artery bypass surgery, or those who are already operated on with an ipsilateral intermammary artery grafted to the coronary with evidence of myocardial ischemia. These are certain indications where the proximal lesions of the subclavian needs to be intervened for. Surgical treatment options with uh, uh, for patients with Raynaud's is the thoracic sympathectomy, uh, where uh, 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 here with the thoracic sympathectomy, usually um, the second, third, fourth, and the fifth thoracic ganglia of the sympathetic chain are usually identified and excised. There are certain options. One is the open laparoscopic and the chemical options, where we usually uh, uh, the thoracic ganglia uh, here is treated, excised, and then the patients are treated for peripheral vasospasm. Here, this is usually indicated, there is only temporary relief of symptoms, but usually patient tend to get symptom recurrence within 3 to 6 months, which is attributed to the rich network of collateral pathways in the upper extremities. As an alternative, peripheral arterial digital sympathectomies can be performed, which has been suggested as one of the superior strategies, and a number of small series usually claim long-lasting benefit with this. Usually, the other options in the upper ischemias are the endovascular and the open bypass surgeries. Endovascular angioplasty stenting for the subclavian artery occlusive disease with a primary patency of 90% at 1 year and 80% at 5 years, most commonly practiced. Most institutional reviews describe the treatment of occlusions with the axillary brachial internal arteries, which involve a surgical bypass or embolectomies. In patients presenting with acute upper limb ischemias, usually prefer a transbrachial embolectomy, where usually the thrombus involving basically the distal brachial, radial, and the ulnas, performed under local anesthesia or with the monitored anesthesia care. Occlusion of the distal brachial artery important to explore the origins of the forearm arteries, because the embolectomy catheters needs to be passed uh, into the uh, distal branches of the radial and the ulna as well. Transverse arteriotomy at the level of the brachials. clots encountered at the bifurcation are readily removed. The majority of the brachial embolectomies, the brachial artery may be pulses indicative of an embolus lodged more proximally. With the consensus, the proximal passage of dislodgement of the debris that may embolize the vertebra near the origin of the subclavian artery that needs to be taken care of, where the risk of untable stroke is quite common. Once flow is established, Fogarty catheters of the sizes 2 or 3 again pass distally down and a retrograde embolectomy is performed. Arteriotomy closure, usually with a fine running polypropylene stitches, is done in a sufficiently large artery, or if it is small, even a vein patch can be considered. Usually, an immediate completion angiography needs to be performed if the hand still appears ischemic, especially if the extensive thrombus has been extracted from the arteries. If there is any suspicion of inflow lesion, intraoperative angiogram needs to be performed by either a femoral or a brachial route to diagnose and treat one Italian study which a significant reduction in the two in patients undergoing or an alternative therapy. Patients of the occluded axillary or the brachial arteries with reasonable outcomes. 8 out of 55 patients required surgical thrombectomy. Thrombolysis has also been described as a treatment option for acute finger ischemia with disease distal to the wrist. In patients with acute iron ischemias following embolectomies may have a reperfusion injury leading to the compartment syndrome. So the pictures depict the fasciotomies that needs to be performed in patients on an untable compartment syndrome, or in patients with an anticipated compartment or a revascularization injury following acute thrombus removal. The forearm compartment, usually in the forearm we have the 3 compartments. So the flexor compartments of the extensor compartments and the compartments along the brachioradialis and the extensor carpi radius longus and the brevis all needs to be released. So on the flexor compartment, we are going to make a curvilinear incision starting from the level of the carpal tunnel and the distal arm, which is curvilinear incision on the forearm, and the dorsum of it is going to be a linear incision, which is between the 2 epicondyles, or you can also take as a landmark of around 2 centimeters lateral to the lateral epicondyle, and reaching up to the tendinous junctions just above the wrist. Patients with chronic ischemia, the innominate of the upper extremity arteries. Symptomatic patients are usually the patients than in the personal disease 49 to 60. Subclavian or the innominate artery stenosis is caused by a number of conditions, with atherosclerosis being the most common cause, followed by Takayasu's arteritis. In 1956, Davis et al. Performed the first transthoracic innominate artery endarterectomy, and a prosthetic bypass grafting was introduced by Devaki in 1958. Because of the considerably high operative mortality rate, extra anatomic procedures were developed. Extra anatomic bypass grafts were reported to bring down the mortality rate from 22% with the transthoracic repair to 5.6% with the carotid subclavian bypass grafting. Percutaneous transdermal angiographic arch branches were introduced in 1980 and has subsequently been evolved as an effective and safe treatment for the occlusions of the subclavian and the innominate arteries. Stenting was initially has been introduced for the management of the subclavian and the innominate artery occlusive lesions in the early 90s to treat failures and also the complications of PTA. This is the initial success of recanalization of occlusions to improve the long-term patency and to protect the atheromatous debris or the thrombus dislodgement during PTA cerebral embolization. Based on these improvements, endovascular treatment becomes the preferred line technique for the treatment of innominate or the subclavian artery disease. Uh, for the subclavian and the vascularization, uh, dedicated with a digital detector with large field of view, high quality roadmap, and sufficient magnetic strongly recommend 014, 018, and guide wires to be semi-compliant balloons, usually of diameters of 6 to 12 mm, of 20 to 40 mm, either in over-the-wire or rapid exchange technology to be made. Various 4 to 7 French sheath with up to 90 centimeters length for the transfemoral approach, as well as micro-puncture sets for the transbrachial or the transradial axis to be kept ready. Usually 8 to 12 mm stents of variable lengths from 12 to 40 mm. Usually balloon expandable stents for treating the osteal lesions to be made available. In self-expanding stents, stent size should exceed the target vessel by 1 to availability of stent grafts and balloons for vessel occlusion is indispensable for the management of bleeding complications. So always stent grafts usually to be made available in case of any unexpected complications following bleed. Innominate artery and the subclavian artery lesions are usually best seen in treating the proximal subclavian lesions. The femoral artery has an additional axis to be used. The axillary artery break being used less frequently. The brachial artery approach offers a better pushability with increased chance of crossing the complex lesions, but is associated with more access site complications. Effectively enable the use of smaller sheets is to cross the lesion from the ipsilateral brachial artery and snare the guidewire from the groin in order to place the stent from the femoral approach. Typically, a long sheath is placed in the aortic arch so that the lesion can be visualized easier or by road mapping, and mostly balloons with diameter of 6 to 12 mm for angioplasty. Previously, stents were used for unsatisfactory periods. Primary stenting is the method of choice. Usually, balloon expandable stents are used for short and osteal lesions. Care should be exercised to place the stent so that it does not protrude more of the right carotid. Specific recommendation regarding the situation of the bovine arch variation. In such a situation, care should be taken to stent across the origin of the left carotid. It is also recommended to avoid PTA or stenting across the vertebral artery region. Patients and the periprocedural care. The interventional antiplatelet therapy should include several 75 aspirin 100 ml prior to the procedure. Alternatively, clopidogrel can be administered with a loaded during the procedure. Heparin administered intraarterially to maintain CT of around T. The post-procedure follow-up. Prior to discharge, access site locations need to be inspected and distal pulses to be checked, particularly if the pulses are used. Except for a completion angiogram, no imaging is needed after procedure. Post-procedural antiplatelet therapy is needed. Double platelet or as described for at least 6 weeks, followed by life therapy. Follow-up should be performed in a 6 months in uh, blood pressure measurements of both the with a Doppler ultrasound. The imaging is only recommended in case of symptomatic patients, with CT angiogram being most common imaging of choice. Surgical techniques, case of innominate direct reconstructions and extra anatomic bypasses. The former may be accomplished by endarterectomy extra anatomic include the subclavian bypass, axillary bypass. The extra anatomic methods are being advocated in order to the two large series of innominate bypasses. The 246 patients reported that the probability of freedom from stroke was 87 to 88% at 5 years, 80 to 81% at 10 years, and the primary graft patency was 94 to 98% at 5 years and 88 to 96% at 10 years. The perioperative stroke and mortality rates of 5.4 to 8%. Subclavian artery occlusions. Open repair for the subclavian artery occlusions include the carotid subclavian bypass using synthetic grafts of the saphenous vein, transposition of the subclavian artery, common carotid. Perioperative mortality is low, and this, that is 0 to 5%. The 5-year primary patency ranging from 92% and 8 to ranging from 8%. There is neither level 1 evidence to suggest support stenting over angioplasty or surgical over endovascular treatment. Proximal subclavian the low mobility of the treatment of choice for bypasses of limbs in care. Here the autogenous route of choice for the upper extremity reconstructions. The GSV is the preferable, although use of the in situ cephalic vein has been described. The more the joints the bypass graft crosses, lower the patency. The excised conduit may be either used in a reverse or the non-reversed orientation. The non-reversed orientation, the anastomosis is performed, the conduit is distended, and the valves surrender in passage of the valvotome. Bypasses originating from the axillary artery are preferably tunneled anatomically of the axillary and the brachial because they are less prone to movement or distortion. However, bypasses based on the brachial artery inflow are most often tunneled along the subcutaneous plane. This facilitates the physical examination for revelation of bypass patency, ensures surveillance with duplex, and avoids manipulation of the rich forearm nerve network. Alternatively, if good quality basilic or the cephalic veins are present, an in situ bypass may be performed. In case of distal radial reconstructions, the graft is tunneled subcutaneously over the extensor pollicis tendons towards the anatomical snuff box onto the dorsum of the hand. The bypass ends between the thumb and the index finger where the deep palmar arch is exposed. In case of ulnar side reconstructions, the course of the vein graft is more direct and it passes superficial to the flexor retinaculum in the subcutaneous plane at the wrist, lateral to the pisiform bone to join the superficial palmar arch. Management of dialysis access steel syndrome, part of the ischemia. In the first picture, you can see we do a AV fistula approximately PFE graft and narrow the vein at the site of the anastomosis, making sure the distal is improved and distal arterial flow is improved. With respect to that is distal revascularization with interligation just after the anastomosis of the vein, the artery is ligated ligation, where the suction effect of fistula is reduced. A long bypass is being made from the proximal part of the artery onto the distal artery. Ensure the distal flow to the artery is maintained. The one is Rudy using distal inflow. Here the fistula is the vein ear is ligated and a and a inflow is taken from a distal artery. Uh, More distal artery, as we can see using a bypass graft. It could be either a vein or it could be a synthetic graft. The other one is proximalization of the arterial inflow. Here the AV axis, the vein here is ligate. The uh, the arterial inflow onto the vein is taken from a more proximal part of the artery, reducing the symptoms of steel. Uh, Despite best efforts with the endovascular and just in case of persistent ischemia where there's extensive tissue loss, we consider upper extremity amputations. Incidence of upper extremity amputation in uh, the US being around 1,85,000 patients each year undergo the amputation, where almost 10 to 25% of the amputations involve the arm and the hand, and the 93% involvement of the amputation is at the wrist or within the digits. And a total incidence of amputation in the developing countries were around total of 2.4 million amputees, of which 15% amputations are below the elbow. Below elbow amputations contributing to around 1.4 million. Below elbow and the elbow disarticulations of around 0.7 million. Shoulder amputations of around 0.2 million. Amputations of around 0.2 million. Uh, Usually, patients subjected to amputation are the ones with uh, traumatic disease, trauma being the most common cause, around 80 to 90% of patients, and other vascular diseases with tumors, vasculars contributing 7% and tumors contributing to about 0.6%. The less frequent causes like infections secondary to diabetes, immunocompromised states, congenital anomalies, uh, atogenic reasons such as complications related to catheterization, vascular access complications, and those with vasospastic disorder, small diseases, and radiation-induced arteritis may be subjected to amputation on the clinical conditions. The general operative considerations for amputation basically include an upper extremity amputation. We need to make sure it is both functionally and cosmetically acceptable to the patient. Healing usually occurs at the hand level. The distal pressure is more than 40 hg, and the uh, um, uh, wrist pressures are more than 60 mmHg. At the forearm and the arm levels, healing will almost always take place when the wrist or the brachial pressure at least 60 mmHg or when the TCPO2 is more than 40. Preservation of adequate stump length. Soft tissue coverage. Usually skin grafts, free flaps, and the composite tissue transfers have dramatically changed the approach, making better stumps. Coming to the specific amputations, usually fingertip amputations, usually crushing blows such as from a closing door. Uh, Here the proximal portion of the distal phalanx, if not severely injured, preservation of the bone is indicated for a functional length. If these are damaged beyond repair, then disarticulation through the distal interphalangeal joint is indicated, and the bone of the distal phalanx should be of adequate length to support the nail bed, the nail growth. The distal nerves are identified, distracted distally, and divided so that they'll be at least 1 centimeter from the fingertip stump to avoid neuromer formation. If the post amputation, if the final cutaneous defect is less than 1 centimeter square, simply allowing the wound to close by secondary intention is acceptable. If the cutaneous defect is more than 1 centimeter square, then a skin grafting is possible. And usually the donor sites for the skin grafting could from the ulnar border of the palm, the forearm, the medial portion of the forearm, and also the groin, well hidden donor area. Color match may not be good. They're going to be with the fingertip amputations. Flap closures were considered the most commonly the cutler flaps, the lateral VY flap closures. In case of a central tip defect, the fingers and the toes where the tips are destroyed, the central tip is destroyed, but the nail matrix is still intact. So here the skin with the subcutaneous tissue on both the lateral side, on the both the lateral sides of the nail is being raised as a flap with the skin and the subcutaneous tissue, and they brought up and closed centrally, forming a VY flap as shown in the depicted in the picture. Other flap is the atasia flap, is a similar VY flap but mostly on the palmar area. Here it's based on the distal neurovascular bundles in which the entire soft tissue coverage of the digit above the tendon sheath is elevated and advanced to cover the tip of the finger. And the amputations at the level of the digits, the midfinger amputations. Here the amputations that leave more than half the proximal phalanx are usually functional for the patient. Amputations which are proximal to the mid portion of the proximal phalanx is not typically a functional. If enough digit remains, it may be possible for patients to wear a cosmetic prosthesis that may allow some functional restoration. However, most patients find remaining digit a nuisance. Reamputations uh, includes removal of the injured finger up to the metacarpal base, often provides a far more cosmetically acceptable hand. Dorsal longitudinal incision over the index metacarpal along with a palmar skin incision over the proximal phalangeal level is the usual incision that is made, and sometimes an alternatively circumferential racket incision may be used. This procedure usually narrows the palm by around 20-25%, which reduces the hand's ability to stabilize objects. More extensive procedures may cause proximal postoperative pain, edema, and stiffness. Thumb amputations. Thumb usually accounts for about 40% of the functions of the hand, so it deserves special attention. Standard of care is now to attempt reimplantation of the thumb, and encouraging results have been achieved after avulsion injuries. Non-reimplantable amputations at the level of the interphalangeal joint are usually functional. In case of more proximal thumb amputations, thumb reconstructions can be done. What procedure we call it as polycization. Here, a functional thumb is being created by a, a finger at the cost of another finger, that is usually an index finger, by myodesic techniques or by usually bone lengthening techniques. Wrist amputations. A transcarpal amputation allows supination and pronation of the forearm as well as flexion and extension at the wrist. This articulation is preferred to more proximal forearm amputation because it helps in the it has same supination and the pronation of the forearm, except that the wrist flexion and the extensions are lost. Uh, Wrist disarticulation is performed by creating a long palmar and a short dorsal flap, ligating the radial and the ulnar arteries proximal to the wrist, identifying radial, ulnar, and median nerves and distracting and dividing them, dividing all the tendons, disarticulating the joint, and respecting the tips of the ulnar stellate process is the major operative technique considered, and the resultant smooth contour can be easily fitted for a prosthesis. Forearm amputations. The optimal level for the forearm amputation is the junction of the middle and the distal third of the forearm. And the issue with the distal third is the relative paucity of padding in this area because of the thin subcutaneous and the subcutaneous tissue and the skin. This factor can be more evident in patients with ischemia because this area is notably prone to skin breakdown. Operative technique includes creation of equal anterior and posterior skin flaps with ligation of the radial ulnar arteries, distraction division of the median radial and the ulnar nerves, and transection of the muscle bellies with division of the radius in the ulnar bone and closure of the deep fascia followed by the skin. However, as described by bilateral upper extremity amputations can be functionally improved. Rukenberg procedure in which a sensate pincer is being created between the radius and the ulna. The pincer is motorized by the pronator teres muscle, and this procedure allows preservation of proprioception and stereognosis. Uh, Although this is not that cosmetically desirable, the functional improvement is great. The procedure should be given a serious consideration, especially in patients with bilateral injuries, in blind individuals, and when the prosthetic reconstruction is not practical. Elbow disarticulations. If the elbow joint is not salvageable, elbow disarticulation is preferred over distal humeral transection. In addition to maintaining humeral rotation can be transmitted to the elbow, and the broad flare of the condyles make a good prosthetic fit. Yeah, similarly, the procedure technique includes anterior and posterior skin flaps, which are created. Brachial artery is ligated, median ulnar in the radial nose are distracted, and joint capsule is open, and the forearm is removed, and a muscle flap, usually the brachialis and the triceps, is then used to cover the. There has been emphasis on retaining all of the humerus if possible. However, so the upper part of the forearm may appear longer than normal and when fitted with an internal joint elbow prosthesis. It is possible to use an external elbow joint, but these are substantially less durable. Considering the upper arm amputations, transcandalar amputation functions essentially the same as an elbow disarticulation. Taking into account the location of the elbow lock, which usually extends 4 centimeters from the distal amputation side, the transhumeral amputation should be usually 4 centimeters proximal to the elbow. Use of free flaps can provide additional soft tissue and bone length for short upper arm amputations. Functional restoration of the glenohumeral joint may be accomplished with a free fibular transfer. Usually, an alternative technique used to achieve adequate bone length is the Elisaros technique. Shoulder disarticulation and the four-quarter amputations or the scapulothoracic amputations, most complex and difficult procedures from a prosthetic and functional standpoint. Uh, Considerations are loss of potential motor units as drivers of the prosthetic device and difficulty fitting the prosthesis to the contours. The shoulder disarticulation leaves a contour adequate to provide a snug fit for the prosthesis. In addition, scapular function is retained and can be used as a motor unit for the prosthetic device. Surgical techniques. The shoulder disarticulation may be modified by retention of humeral head to assist in contouring, or maybe a true disarticulation with complete removal of the humerus. The deltoid and the pectoral muscles, along with the uh, overlying myofasciocutaneous tissues, provide adequate flap coverage. The deltoid is not available, and inferior axillary fasciocutaneous flap may be necessary. The latissimus dorsi and the pectoralis major are reattached to the glenohumeral or the head remnant. The tendinous components of the rotator cuff are also attached to the glenoid capsule. There are two approaches to the four-quarter amputation. One is the Berger, that is the uh, anterior approach, and the posterior approach, the Littlewood approach, which only differ in the exposure of the vascular structures hidden behind the clavicle. Usually, the post-operative management and complications following patients. There should be low threshold for areas of drains, for drains in the areas of potential spaces, which is responsible for hematoma and seroma formation. Early physical activity and rehabilitation, compressor dressings, full range of motion exercises of the elbow and the shoulder should be started immediately when the structures are preserved. Over wound healing and concerns of land ischemia, stump necrosis are less well appreciated in the upper extremity amputation. The threat of rhabdomyolysis and myoglobinuria uh, are much less than in the lower extremity because of the small muscle mass and the short arm length. Revision amputation patients undergoing transradial amputation 4.7 times more likely to have a phantom pain. Revision of these amputations resulted in increased prosthetic use from 19% to 87% post-revision. Phantom pain usually seen around 40 to 80% of patients post-amputation. A loss of the dominant hand is an independent predictor for the development of more significant phantom limb pain. Actually, there are pharmacologic techniques where we use tricyclic antidepressants, SSRIs, SNRIs, anticonvulsants, being a part of the pharmacologic treatment of phantom pain. Surgical treatment where the nerve bundles are microscopically sutured and covered over the tissue ends, and keeping them far as away from the amputation surgical site to prevent the phantom pain. Psychological therapy, that is the mirror therapy, and also neurostimulatory techniques of deep brain stimulation, motor cortex stimulation, spinal cord stimulation, and dorsal root ganglion stimulation is being performed to prevent phantom pain. Compared with lower extremity amputees, those losing the part of the arm or the hand suffer from a higher rate of psychological disorders such as depression, anxiety, and post-traumatic stress disorder. And this 30 to 40% of these upper extremity amputees will require psychological care. Rehabilitation for those with upper extremity amputation is more complex compared to the lower extremity because of the intricate movements and the fine sensory motor functions in the arm. Principles of upper extremity amputees rehabilitation include residual limb soft tissue shrinkage and shaping desensitization, maximizing the range of motion, skin health and mobility, augmentation of self-reliance and daily activities, and exploration of prosthetic options. Prostheses that are usually available are purely aesthetic ones. As shown in the figure, purely aesthetic prosthesis usually consists of silicone and a made a lifelike appearance, so that can have a relatively normal body habitus but very minimal in function. As a body part prosthesis, here simple mechanical devices that are controlled by residual body motion and function are used. Most durable of the prostheses are these body powered prostheses and are used for significant physical activities. Those mostly used for swimming, rock climbing, and performing the most athletic activities. And the others are the complex myoelectrically controlled prostheses. The use of electrodes to convert the electrical stimulation of the residual muscle groups into a current to power the prosthesis. Usually, wrist rotation, finger movement is a reality, and terminal devices may be attached to the prosthesis to allow various functions. However, they are more complex, more expensive, and less durable for hard physical activity. The residual muscles are surgically re-innervated for maintenance of cortical functioning to enable muscle contraction and thus application of the myoelectric prosthesis. This allows amputees to simultaneously open and close the hand and flex and extend the elbow. And the other option being that transplantation was performed in 1964 and it failed, secondary to acute rejection. Since then, 70 hand transplantations have been performed as at 2013. In a review of 5 bilateral hand transplant patients with a mean follow-up of 7.6 years, Bernatron et al. Found that physical results achieved were considered fair and the functional results were considered good. The ethical dilemma is weighing the perceived benefit of hand transplantation in regard to expected quality adjusted life years versus the effects of long-term immunosuppression.